Well, good evening and welcome everyone. This is our 11th Women's Wellness Fund event, which I can't believe we're already at 11. Managing aching joints, my aching joints, managing arthritis and joint replacement in women is our topic tonight. Those of you who don't know me, my name's Laura Martino and I'm one of the vice presidents at the hospital. And I'm very excited to have all of you here this evening. It's really been a lot of effort, but worth the effort to try and figure out facilities that we can have at least a small portion of our larger women's wellness group to see the presentation live. There's a number of you here tonight, but we also have about 40 or so folks joining us by Zoom. And I know after our last event, we had an additional 40 or 50 or so people watch the recorded presentation at a later date. So even though we can't all be together, we're still able to reach out and get to inform those of you who are part of our Women's Wellness Fund. So thank you again for coming. I'd like to thank our generous sponsors for tonight. We're Sally Meyer, the Peach Pit Foundation, Middlesex Cardiology Associates, Radiologic Associates of Middletown. So I always get this wrong. Doesn't want to move. Okay. Using the arrow.
Oh no.
I might have gone to speak.
There we go.
Okay, thanks. So as you all know, the Women's Wellness Fund advocates for, educates about, and funds priority women's health projects in our community. And we are very, very pleased that over the years, we've really been able to bring such a large number of women throughout our community together to stay informed about different services and learn about what's different about our bodies when in regards to healthcare. So our steering committee, some of you are here tonight, has been an invaluable resource to us. They help advise us on topics that we should have covered. They also advise us on some of our funding priorities and areas that we want to support. So we appreciate their help. And I also want to thank our team here. I think they go unnoticed a lot of times, but they do a lot of work behind the scenes. And I just want to give a little shout out to them for trying to put all this stuff together because they work very hard to do so. So I will, at this point, turn things over to Sarah Moore, who will tell you a little bit more about the Women's Wellness Fund.
Thank you, Laura. And I'm gonna get some hand sanitizer. All right. I want to share just, this is our current steering committee. We have a great group of women from throughout our county, retirees and women still working. Anyway, we're really happy to have them help us set our direction. So I'm just going to touch on what we're funding this year. Since we were formed in 2017, we've raised $175,000 for a number of women's health projects. And this year we're happy to be focused on 4 things. So the first is identifying women at high risk for cancer. And we're doing this at the mammogram appointment. So we do 23,000 mammograms at Middlesex Health across 4 different locations. So it's a perfect opportunity to identify any women who might have some risk factors, higher risk factors for breast cancer. And so we started with a piece of paper, tested that out. It went really well. Now we're going to an iPad to make it a lot simpler and the referral process easier. So that's one thing. The other thing is a new center for integrative medicine and wellness. We provide all sorts of alternative modalities, Reiki, massage, acupuncture, and we're creating a new home for that. Right now it's currently located within our cancer center in Middletown. And so we're creating a new home. The construction, unfortunately, is on hold. There's a governor order against any non-essential construction in healthcare, and we've been trying to overcome that ban, but we haven't been able to continue with that project right now. So we'll let you know when we can. And then third, we are funding a genetic testing study. This is a really pioneering study that we're happy to be a part of. And it's to identify any genetic mutations that may be missed in the current screening protocol. So not everyone who's diagnosed with cancer is recommended for genetic testing right now. And this is to test whether or not we're missing some potential genetic mutations that would alter the treatment plan and the screening protocol. So we've enrolled 70 patients so far, and we're looking to enroll 300 over the next few months. And then finally, we're very happy to be supporting the perinatal social work program again this year. It's the 4th year that we're doing that, and that's supporting pregnant moms who are facing unusual and really challenging circumstances in their lives. Could be related to domestic abuse, food insecurity, housing insecurity. So we have a referral source. We have a social worker who works directly with all of these women, about 80 or 90 per year. And the outcome that we measure is a healthy birth weight. And so 99% of the women that go through this program achieve that with their birth. So I'm going to shift gears, and I'm really pleased to introduce Dr. Amy Wasterlain, who's an orthopedic surgeon. She will tell you a little bit more about herself, but she specializes in total hip and knee replacement and revision, and she practices with Middlesex orthopedic surgeons and does perform surgeries at Middlesex Hospital. Just a little bit of housekeeping. We will take questions from those of you here at Parmalee Farm. We will also take questions from those on Zoom. If you're on Zoom, please use the Q&A so that we make sure to see your question, and we'll try to get to as many as we can. And we will, Dr. Wasterlain will repeat all the questions so everybody can hear them clearly before answering them. So I'm going to turn it over to Dr. Wasterlain. So welcome. Thank you.
Thank you. Is that a Yolanda out there? No. I want to give a personal shout out to my patient Yolanda, who just had her hip replaced last Wednesday. It's awesome to see you. She's already out and about. Big round of applause. So my name is Amy Wasterlain. I do hip and knee replacements at Middlesex Hospital. This is just my educational background, but basically I'm from New York City. I went to Princeton and then went across the country for med school, and then came back and did my residency at NYU. And then I spent 1 year in Philly, and now I've been in Connecticut. This is my 2nd year, and we're loving it. So the things that I love, I went to fellowship just for hip and knee replacements. So in 2019, I did 300, just specializing only in that. So I love minimally invasive hip replacements from the anterior approach in the front, and minimally invasive knee replacements using a special technique where I get to scoop under the muscle instead of cutting. So I'll tell you more about that, but I'm also now sort of the community's repository for all the complex disasters that have happened, you know, and have been neglected for many years. So I'm happy to tackle those big challenges too. I have offices that are very far apart and require a lot of driving, but I'm down for it. So tomorrow I'm in Westbrook. I do Mondays and Tuesdays in Middletown and Tuesdays in Hebron. So you can find me far and wide across the state. I live in Guilford with my husband, Jordan, my son, Hudson. This was in the Cape like last weekend. My daughter, Vera, she's 9 months, and a cute dog. I actually replaced the breeder's 2nd hip today. So making good relationships. I like to ski, hike, quilt, and dance. So I was going to talk to you guys first about normal hip and knee anatomy, because you have to kind of understand what it should be in order to understand what's going wrong. Then we'll talk about arthritis, what it means and how to diagnose it, and then some early treatment options and a little bit about surgical options. Does that sound good? Any questions, issues? Good. So this is a knee. On your left-hand side, it shows all the muscles and ligaments attached, and on the right-hand side, it shows just the bones with the cartilage. So can you, can you see this mouse cursor? So there's purple here, and that's representing the cartilage. It should be smooth, all continuous without divots or wear. And then over here, these are just the muscles that attach everything. One important part of the knee is also the meniscus, which is this sort of C-shaped thing. You have one on the inside and the outside of your knee, and that's basically a shock absorber. So when your meniscus and your cartilage get shot, that's when arthritis sets in. So if you just want to translate the pretty diagrams we just looked at into what an X-ray looks like, here, the bottom part, this is the tibia bone, and this is the femur or thigh bone. This circle here is your patella or kneecap. And the main thing I'm looking at is how much space do you have here between those two bones, and is it even and symmetrical? So these are 3 views now of normal knee x-rays. So on the left, you can see there's this beautiful space. That makes me very happy. That makes your knee very happy. Same thing in the middle picture. This is a side view, and you can see beautiful space between the kneecap here and the femur. And you can also see the space between the femur and the tibia. And then finally, this is another picture of a kneecap and the beautiful space in between. And that space is essentially cartilage. Cartilage doesn't show up on X-ray, so the presence of that space implies that there is good cartilage. Does that make sense so far? Looking good? So now we're just gonna do the same thing for hips. So here, this is the socket of your hip, and this is the ball or the femoral head. And both the socket and the ball are lined with cartilage, just like in the knee. Now here, imagine this is, if I took my socket and my ball and I just opened it up so you could see behind. So here, this is showing you this purple cartilage on the ball. In real life, cartilage is white, but whatever. And then you have a nice ring of cartilage inside the socket as well. So this is a normal pelvis x-ray, and things that I'm looking for are, so here's your socket, here's the ball. The ball looks like a really nice sphere. I could probably draw a perfect circle around it. It doesn't have lumps and bumps and spurs, and it has a very nice symmetric space between the ball and the socket here too. And same thing is true on the other hip. So this, I think, is kind of fun. So now we talk about women specifically, because it's amazing that I have a group of all women here, and very rare in orthopedics to have any women. So what are the differences that make a difference for you as a woman? So one of the most important things is called the Q angle. Don't worry about the details, but essentially it's a measure of sort of how wide out your hips are relative to the angle in your knee. So it's a measure that relates your kneecap, your pelvis, and tells you how likely you are to have issues with your knee alignment. So women tend to have a bigger Q angle, and that makes us slightly more knock-kneed on average. Most people with arthritis still have bow legs, so I'm not saying everyone's got knock knees, but compared to men. So that puts more pressure on your hips and knees. Women also have more relaxin, which is a chemical or a molecule in our bodies. For example, it increases a lot during pregnancy and loosens your ligaments. And then we also have more supple muscle, which is fantastic from a surgeon's perspective and therefore from a patient's perspective, because it makes any intervention that you do need to do quite a bit easier. So now we're going to talk about what arthritis is, and you all already sort of have an idea based on the normal anatomy that we discussed. So here's that healthy joint that you saw before with the beautiful white shiny cartilage and those meniscus pieces here. Now, once your arthritis progresses, basically you get lots of wear and tear on that cartilage. So you get big divots. The space between those two bones gets narrow, and you start to get some bone spurs. I'm having trouble with this. There we go. Like this here is a big bone spur. So here, it's really just showing you that there's a progression, right? It starts out mild, you have a few aches and pains every now and then, only when you're going up and down stairs, for example, and then eventually it may progress to doing the most basic activities, like putting on your shoes and socks, bending down to feed the dog, things like that. So here we go. What are the signs and symptoms of knee arthritis? So I hear a lot of people telling me that their knee feels stiff, like after they wake up in the morning or after sitting in the car for a long time. They can get knee or even thigh pain. Sometimes you get swelling, and that's because when you're inside the knee joint, the damaged cartilage and meniscus can create increased fluid. Some people feel like their knee is going to give out. Like they just say, all of a sudden I felt like it buckled. Pain walking, going up and down the stairs, sometimes kneeling, gardening. It's usually with these really just basic, important daily tasks. So here's the X-ray comparison. On your left side, you've got a normal knee joint with normal space here between the two bones. And then on the right, you can see this person is actually bone on bone. And that hurts. Every time I see that in a patient that walks into my office, I have this like overwhelming feeling of like, ugh, I'm sure that really, really, really hurts. And I seriously empathize with what that must feel like. This is actually a knock-knee alignment, so this might have been a woman. If this progresses and you ignore it for a long time, it can actually lead to a deformity. So here, you can see that this person is bone on bone on the inside parts of both of their knees. And it started to erode away some of the tibia bone. So this person is really developing a bow-legged deformity that can completely change your gait. I've had patients with very bow-legged or very knock-knee deformities asking me if I can lengthen their leg because it feels like their leg is short since it's so deformed. Questions about knee arthritis before I move on? Is that okay to do like in the middle, or do you want it to be at the end? Yeah. And we'll still obviously have time at the end. Nothing yet. Yeah, just if you, I don't want to like overwhelm people. Yeah. Yeah, any of the above, like all of those can be consistent. You know, I mean, usually for treatment, I would expect somebody to have more than one of those issues, but even just one of them, you know, it can start if you have mild arthritis with only pain when going up and down stairs, but not when walking and not when doing basic things. Anyone else? So hip arthritis is really the same exact concept. You've got here that diagram that you recognize with the nice cartilage in the ball and socket joint of the hip. And then on the right side, we have destroyed cartilage. So that blue layer is thinned out, and huge bone spurs, all in here, all in here. And you can imagine anytime you rotate that hip, it's just bone grinding on bone and causing a lot of pain. So hip arthritis has similar but some different symptoms. So the most common location that people have it is in their groin, or sometimes people will say it's like in a C-shaped area around their groin going into their buttock. Hip arthritis can also radiate down the thigh. So occasionally people don't even really feel like they have buttock or groin or hip pain, and it's just all thigh and knee pain. There, you know, things like twisting activities, like golf, I don't know, vacuuming, anything that involves rotation can be really painful. Going up and down stairs, often getting in and out of a car, like just picking up your leg, putting on shoes and socks. I don't know if Yolanda, you want to share anything else about? It's like, please no. Yeah. Yeah, Yolanda's saying it was, I'm just repeating for the Zoom people, that when she had really bad arthritis, it was really hard to get in and out of a car. That's actually one of the questions that I ask people right off the bat, like, do you have pain getting in and out of a car? Because it's so, so common. And debilitating. I mean, imagine if you have pain with your right leg getting in and out of a car or getting on and off the gas pedal. I mean, that's actually dangerous. So here's an x-ray that shows the normal joint space here. And then on the right side, you see there's just no space at all. It's actually bright white. The reason it's bright white is that when you have arthritis grinding bone on bone, your body actually sends more and more calcium deposits to try to help, but it just makes things really dense and heavy and then bright on x-ray. So this is actually a real thing. It's not just the screen looking funny. This shows you 3 of your 4 cardinal signs of arthritis. So here's the, here's the joint space narrowing that you get right there. The sclerosis, that's the word I just used before describing that bright white line. And then the osteophytes are these huge bone spurs right here. And down here's a big one too. If just like with knees, if you let hip arthritis progress a lot, it can lead to deformity and shortening. So here's an example of a patient who had a certain type of arthritis in which the ball of the femur actually collapses, and you can see it looks like a semicircle instead of a full circle. And that leg actually gets shorter and shorter and shorter because you have actual bone loss. All right, so let's talk about what on earth we're going to do about this. It is not hopeless. One of the reasons I love orthopedic surgery is there are tons and tons of treatment options and people get better. So with and without surgery. So firstly, you can start with physical therapy. The one caveat to physical therapy, I just heard a groan, is for arthritis, if it is advanced and you're bone on bone, physical therapy can often make it worse, not better. So physical therapy is something I recommend to my patients with very mild arthritis that I can't even see on x-ray, but I don't recommend it or even ask about it now for patients that have severe arthritis because it's, I think, just a form of cruelty. NSAIDs are very helpful. So if you can take NSAIDs, which is like ibuprofen, Aleve, Motrin, Celebrex, Mobic, all those kinds of things, these do tend to really help with arthritis. The challenge is that a lot of my patients have other comorbidities like atrial fibrillation and might be on blood thinners or things like that. But if your stomach can tolerate it, go for it, it'll probably help. There are also certain types of braces. In general, you know, similar to physical therapy, bracing is not super helpful, but there are certain types, like there's one called an offloader brace that literally applies pressure to your knee to try to open up that space that was collapsed down. When it works, you know, I have a few patients who love this. It does put a lot of pressure on your knee though, and it costs a lot of money. So, you know, for some people, this is helpful. Canes can be helpful. I see a few in the audience. I'm happy to see that. Usually they're most useful in the opposite hand. If those things fail, then cortisone injection can be super helpful for people and really can buy you some time to get through an important time in your life. So for example, if you have a child getting married or it's the holiday season and you just really want to get some relief for a few months, it's temporary, but it does tend to be really effective even once you've got pretty severe arthritis. So this is always my first, you know, go-to. Even when I think someone needs a knee replacement, I offer them a cortisone shot to start because I think you deserve to try all the non-surgical things first. Yeah. So great question. So what does cortisone do? So it goes in the knee joint where the cartilage is supposed to be, and it calms down the inflammation. So it's really a biologic mechanism. It takes a few days to kick in, but it usually gets people about 3 months of relief. Depends, yes, it can be. It's not too bad. It can be, so it doesn't have to be a series. So usually, you know, it's one at a time and you can do it every 3 months. So I have some patients that keep coming back, you know, wanting it every 3 months, and that's fine. For some people, it stops being as effective over time. So the first one lasts 3 months, the second one lasts 1 month, and then at some point it isn't as effective anymore. But yeah, you can just come for a one-time deal. Yeah. Great question. So is there any adverse side effect to cortisone? There is, in the sense that it can over time damage your cartilage more. So I don't recommend it for 20-year-olds that should have perfectly intact cartilage. But if you are already down the arthritis pathway, I don't think that side effect is clinically meaningful. It can also raise your blood sugar. So if you're diabetic, you need to just, I tell my patients to be mindful and check their blood sugar a little bit more than they usually would. Yeah, those are the main things. Anyone else? Gel and visco injections. So the Orthopedic Academy currently does recommend cortisone and does not necessarily recommend gel. In some people, this seems to be super effective, but it's only about 50% of people that respond. So in my hands, cortisone's the go-to, and only if that fails and you're not, you know, ready for or wanting to have surgery, do we then try gel. But it can be yet another option in our arsenal. And this can, in answer to the question before about how many shots you get, this you can get either as a 1 shot or as a 3 series. And some of it just depends on insurance authorization and stupid things that shouldn't be running our healthcare system to do. Okay. So finally, we'll talk about surgical treatment options, and then there's still plenty of time for Q&A. Cool. Okay, so arthroscopic surgery, or a knee scope, you may have heard of. So this is when they make 2 little poke holes, use a camera and use a shaver, some small instruments. It's outpatient surgery. So this can help some mechanical symptoms. What I mean by that is like locking, clicking, catching. From a simple meniscus tear, you remember the meniscus is that's those 2 shock absorbers like this, or a labrum tear, which is basically the bumper in the hip. But I really urge caution in arthritis. There are numerous research studies showing that this does not help in arthritis. It's tempting because it sounds nice to be able to just shave away the bone spur or whatever your personal issue is, but it unfortunately really doesn't work because it doesn't restore any cartilage, and it doesn't change the course of the disease. So I think it's sort of like treating it's like shaving cheese with a cheese grater. Like, it's gonna fall on the floor. I could sweep it up, but it's gonna keep grating and falling on the floor. I don't know if that makes sense. So beware about arthroscopic surgery for arthritis. Then there is another treatment called a partial knee replacement, or a uni. And this is a fantastic procedure for patients that have arthritis in just one part of the knee. So if you remember, I talked about 3 different parts. There's like the inside part, the outside part, and then under the kneecap. So if you just have one of those 3 affected, this is fantastic. It feels more like a real knee, like the knee that you were born with. I use robotic navigation for it because it's really important to be precise within less than 1 degree so that you can match your native anatomy. This is very similar to a uni. So this is a patellofemoral. Patella means kneecap and femoral is the thigh bone. So you can see here, this is a picture where they've replaced just the area where the kneecap rubs on the thigh bone. And the patients do really well with this if their only issue is arthritis in the kneecap. If you have arthritis in more than one area, however, or if you have a deformity, you're really looking at a total knee replacement. And in a total knee replacement, oh, I should have brought models. Sorry, guys. Thinking out loud. So in a knee replacement, there is the femur piece. So that's the femoral component. And this is usually made out of a very shiny metal or oxinium, which is like a new ceramic metal composite. There's a tibial component that goes here. So that's the silver part right there. And that's made out of titanium. And then there's a plastic polyethylene liner that goes in between. Another thing that this diagram does not show is that the back of the kneecap, we also put a piece of plastic so that that moves smoothly. This is what a replaced knee looks like. The bright white is the metal, so there and here. And you can see that space is restored now with that plastic piece. So one of the things that I trained in and have been doing for all my patients recently is called the Subvastus approach. So your knee incision is going to be the same no matter what. You know, we have to make a certain amount of incision just to put the implants in. But the traditional approach is this red one. So basically it goes down the middle of the quadricep muscle, around the kneecap, and then down the shin bone. And this works great. I'm a fan of it. It's fantastic, especially for patients with bigger deformities. But what I found is that when I don't use a tourniquet, so I'm not cramping down the thigh muscle, and when I scoop underneath the quad muscle instead, patients are recovering so much faster and able to just lift their leg and feel less debilitated and up and walking sooner. Yeah. So do you want me to repeat the whole concept? Got it. Okay. So the very traditional approach for a knee replacement is you use a tourniquet to try to make it, less bleeding and make it basically an easier operation. And we use this red incision line, trying to highlight it there, which is called the medial parapatellar approach. Don't worry about the name, but basically it goes along the quad, around the kneecap, and then down. What I've been doing is the subvastus approach, where it scoops under the quad muscle. If you see like that blue line, it's going around, not through the quad muscle. And I've found that patients have less thigh pain and are able to actively straighten their leg sooner with less discomfort. So for my patients and for me, it's been really successful. And interestingly, I haven't met anyone else out here in this area that's doing that. But there's a few in New York and a few in Philadelphia where I trained who were doing it that way. Hip replacement. So for hip replacement, if you look at this picture on the right, we essentially resurface the socket, so we make it a perfect hemisphere. There's a titanium component that fits in, and it's really cool. It has a sandpapery surface and actually grips onto your bone, and then your bone grows into it, which is really helpful for longevity. It helps reduce the chance that it could get loose or that it could wear out. And then on the femur side, there's a stem that goes on the inside of your hollow bone, and that also has that sandpapery surface and gets a grip to your bone. There is a ball, which today's gold standard is ceramic ball, and a fancy plastic. So the gold standard today is ceramic rotating on plastic. And I think that that will probably remain the gold standard for quite some time. It's got really good track record and doesn't create a lot of wear debris. So here's an example. This is one of my real patients. You can see, which hip do you guys think has arthritis on your screen? The left side on the left screen or the part on the right screen? Yes, good job. Okay, so you can see that there's narrowing, right? The space between the ball and the socket is basically completely gone. There's that bright whitening, the sclerosis. There's some bone spurs. If you look, like this is a bone spur here. So this is after surgery. She texted me the next morning saying, "I can't thank you enough. I'm feeling pretty good." Smiley face. So I felt pretty good about that too. And like I said, we have our own patient that we can hear from today. So in terms of hips, I'm doing the direct anterior minimally invasive approach. So that is a smaller incision. It's about the width of my hand, and it leaves all muscles intact. There's a lower dislocation risk. Honestly, almost all of the risks are lower in this approach. So I'm very happy with it. My patients are up and walking the same day. I have a few who've had like a posterior approach, a few years ago, and then now had an anterior approach, and subjectively tell me that the recovery is easier. Outcomes long-term are the same. So, if you had a posterior approach hip, don't stress. Your long-term outcome is just as good as everyone else getting the anterior approach. So that's all I have from me, but I'm delighted to hear from you guys about what you want to hear more about and questions. Yeah. Perfect. Great question. In general, not, oh, sorry, yes. The question is, are there any side effects to using a gel injection? So for the most part, there are not many side effects. Anytime you inject anything into the hip or knee, you could theoretically increase your risk for infection. So that's true with cortisone and with gel, anytime you get a shot. There are a few people that have an allergy to the product in the gel. So it's made out of something from the rooster body, like literally chickens. I don't understand all the details. The molecule is hyaluronic acid, but if you're allergic to eggs or chicken products, then that's not advised. And then question number 2. Yeah. Oh, nice. Okay. So a bone spur is an overgrowth of your bone, and it occurs when the cartilage is worn out. So you've got cartilage on cartilage, it wears out. Now you have bone grinding on bone, and your body attempts to increase the surface area based on that physics concept we learned about in high school, where more surface area means less pressure. So your body's trying to help by making these bone spurs, but it actually just creates an additional source of friction. How do you get rid of them? So the honest truth is you really can't in a meaningful way except with hip or knee replacement. And the reason is the bone spur is basically a symptom of the underlying problem. So even if you were to go in and physically remove that one bone spur, the process is already in place and is going to reproduce more of them. So there isn't really a meaningful surgery in the vast majority of cases that would remove a bone spur. Yeah. Yes, so the question was, what's my feeling about the process to regrow cartilage? I think it sounds very promising. It addresses the biological aspect of arthritis, right? So if you could physically regrow cartilage, that would give you a new coating. I'm a little bit skeptical because I don't think it will address the mechanical aspects of it. So, you know, if you're developing like a knock-knee deformity, it's about more than just pumping up that space. I don't know, I'm watching that research come out with eyes open and ears open, but it is absolutely not something I would recommend to an actual human that comes into my office in 2020, or probably even in 2022. You know, maybe in the next 5-10 years, we'll have something meaningful. Yeah. Anyone else here? And then more, yeah.
On the hip photo, I could see where the piece goes into the hip.
Yes.
With the knee, what is it going into? How do you make it stable?
Such good questions. Okay, so the question is, it seems obvious in the hip replacement that you're putting the socket and the stem into the bone, but where does the knee replacement actually go into? So in general, a knee replacement is sort of more like a resurfacing. So we're essentially filing down and preparing the outside of the femur bone to take an implant that goes on. Let's see, so that these guys can see it too. Kind of like this. So it's like a cap almost. In a knee replacement, they get cemented on. It's bone grout. There are cementless knees that have a press fit and a grippy surface, just like the hip ones do, but the research is still preliminary on those. So I think that will be a technology that's much more common in 2022, 2023. But right now, the gold standard is to basically glue it on. I went to med school for this. I'm a human carpenter. Yeah. More, yeah. What's up? Yes, fantastic question. Okay, so the longevity of a replacement is dependent on a few things. The two most important ones are the plastic wearing out and whether the components get loosened from the bone. So in the hip situation, I was describing that your bone grows onto the hip replacement. So loosening is not really a big issue in hips. In hips, the main issue is when does the plastic wear out? And what I can tell you is the rate of wear on a modern hip replacement is less than 0.1 millimeters a year. And I always use at least 6 millimeters of plastic. So in theory, you know, you're looking at 50-something years of longevity. I'm not saying that all hip replacements last 50 years, but we have great data that they last at least 20. And that's from the hip replacements that were done 20 years ago with a different type of plastic. So I'm pretty optimistic, to be honest. I think that the hip replacements we're putting on now are going to last quite some time. With respect to knees, so there's data showing that in 20 years, 80% of people still have the same knee replacement. So that kind of gives you an idea. I think it's reasonable to assume you're going to get 20 years out of your hip or knee replacement. Yeah.
Why some people get it and other
Yeah.
people don't get it?
That is a great question. So tell us about arthritis and why some people get it and some don't. So the two biggest factors are, number one, genetics, which you have absolutely no control over and shouldn't feel, bad about. It just is what it is. And there are people who get arthritis at a very young age with no other, clear explanation. The other thing is weight. And, if you compare a 150-pound person to a 300-pound person, the 300-pound person is putting twice the amount of pressure and stress on their joints throughout the course of their life. So weight is one thing you can have some control over. I understand very much so from all my patients that it can be really, really hard. I'm not trying to minimize that, but it's one of the only modifiable things that we can do as humans to make our joints last longer. There are myriad other little things, so alcohol, cortisone, things like that can sometimes cause specific conditions like avascular necrosis, but then I think we're kind of getting into the weeds a little bit. Injury, absolutely. So that's a great point. If you have an ACL injury, that's one of the common ligaments that football players and athletes sustain, that can shift the mechanics of the knee and predispose you to earlier arthritis. So that is a great point. Yeah, if you have an injury where you lose your meniscus or your ACL, that can set you on that path faster. Yes. You are more prone to arthritis if you have had a meniscus injury or tear. If you think of the meniscus as the shock absorber that's preventing the two bones and the cartilage from having a high degree of impact with each other, when you're missing that shock absorber, you have much more direct contact and direct impact of bone and cartilage on other bone and cartilage. Yeah, should we get some from the, or no? Okay. Go ahead. That is a great question. The question is, are they doing research on the genetics? Honestly, I don't know. I'm sure they are. I mean, it just seems like such an obvious. Arthritis is so pervasive, exactly. Yeah, that would be fascinating, and I don't know the answer to that. Yeah. And you said specifically sciatica? Is that what you said? Yeah, okay. Oh, your SI joint, is that what you mean? Got it. So the question is, if you have sciatica or sacroiliac SI joint issues, what can you do related to arthritis? So there are types of arthritis that you can get in the sacroiliac joint, and there are things you can do like cortisone shots. Physical therapy is more likely to be helpful for that condition compared to hip and knee arthritis. But currently there's not a replacement or a, there's not a replacement option. They can do things like fusing your joints, which essentially the concept there is, instead of having a painful grinding, it's better to just have something stuck together that doesn't move and doesn't cause friction and pain. Interestingly, the sacroiliac and SI joint sciatica stuff is usually managed by spine surgeons, so it's sort of at the edge of my area of expertise. Yeah. Were there more? Yeah. Great question. Supplements, helpful or harmful? There is extensive research that things like glucosamine, chondroitin, there's one other one that people often use. Which one? Turmeric. Neither helpful nor harmful. It is harming your wallet. It is probably not helping you, but I also don't think there's any harm. So if you have a personal feeling that they are helping you, then go for it. Because in the situation of arthritis, like, we'll take what we can get, take any extra little win that you can get. But I'm not an advocate because there's truly no research to support it. Yeah. 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 So the honest truth is that exercise isn't directly, like, I don't think it's going to directly help prevent your progression of arthritis. However, that being said, it helps with avoiding weight gain, which we know does directly affect arthritis. And it can often help with muscle balance and diminish some of your joint pain. You know, so sometimes strengthening certain muscles can diminish your joint pain. It's not going to change your overall progression towards arthritis. More remote one. Yeah. Yeah, so there's some research showing benefits of acupuncture. That and chiropractic work, I don't often bring it up to patients, but I'm super supportive if people feel that that's been helpful to them. Yeah, I think I do believe in the power of acupuncture for certain people, and it really can be a helpful pain management strategy. Again, not changing anything about the fact that you have arthritis, but may make it more manageable for some people. Yeah. Okay, great question. Does osteoporosis affect hip replacements? So first, I just want to briefly clarify the difference between osteoporosis and osteoarthritis. So osteoporosis, if you think about the word porosis, it means that there's a lot of pores. So basically it's very weakened bone. So you hear about women who have like hip fractures due to osteoporosis because their bone is weak. Arthritis is completely different. So arthritis is when your cartilage wears away and you've got bone grinding on bone. So osteoporosis does affect hip replacements in the sense that I, as a surgeon, need to be aware of it and be careful not to cause a fracture, right? So those are people who are more fragile, essentially. I don't think in the majority of cases that it would affect your outcome. So as long as nothing bad happens and you don't get a fracture, then your outcome should be just as good. Hip, almost always, I'm going to say hip, for two main reasons. Number one, a hip replacement is an easier recovery. So you're typically up and walking and off of pain meds dramatically faster, you know, in a matter of 1 week as opposed to a matter of 6 weeks. The other thing is that in order to adequately rehab a knee replacement, you really have to have full mobility of your hips because you need to be able to bend and straighten your knee all day, every day, and really work on it. So if you've got a terrible hip and you're hunched over and having a lot of pain with your physical therapy, then it's going to be really hard to rehab a knee. So I will do it in patients who beg me if they meet a whole host of criteria. So you have to be under 70, you have to have a BMI, which is basically your height-weight ratio, under a certain amount, no medical issues, which is essentially my way of saying I really don't recommend it, but if you force my hand and I have no good way to justify not doing it, I will do it. So I've done simultaneous knees on maybe 5 people in the past year, and most of them are, they end up really happy, but it's not pleasant for those first few weeks. Yeah. So much harder, yeah. I was talking to somebody about this earlier today. So we don't 100% know, but the main reason that we think it's so much worse is that the knee is a very tight capsule. So if you imagine like a water balloon and you fill up that water balloon and then you try to bend it in half and you see it stretching and getting really tight skin, that's what a knee is like. The hip is just a more simple, more fluid joint. So it seems like it's related to the tension that's in a knee. Yes. Yeah. Yeah. It's a great point.
you envision doing that?
Yeah. Yeah, so the question was, what are the other differences in hip and knee replacement over the past 10 years besides just the smaller incision? So I think pain management has been one of the most critical changes that we've had. So, 10, 15 years ago, the philosophy was pain is the fourth vital sign, and we just threw opiates at it, and we threw as much oxycodone as we could. We gave patients a personalized pain button, which sounded great, like you're putting control in the patient's hands, but it really was not a multimodal approach. So now we're using all different types of molecular approaches to pain. So you're getting the Tylenol, you're getting anti-inflammatories, you're getting essentially systemic cortisone or prednisone. You're getting some narcotics as needed to cover whatever is left over. I also give people an injection in the hip or the knee during surgery that lasts 3 days. So, that whole approach is just really completely different from what we used to do. And then a huge amount is also patient expectations. I'm very clear in the office that you can do this and you're going home, you're not going to a nursing home, like you are not an invalid. And I think that mentality is very different than 20 years ago when we told people this is going to be a 2-week hospital stay, and that just changes your own expectations. Yeah. The Z line. I'm not aware of what the Z line means. It is true in the sense that you may have a predisposition. So because of genetics, if one person has one joint affected, I have found that that is frequently not the only joint, and they often have others affected as well. But I would not think about this as like getting your hip replaced then leads you to needing a knee replacement. That is definitely not anything that I've seen or heard of. Yeah. Yeah. I have not heard of that. I'm interested. In almost all cases, scar tissue is a challenge that we have to deal with, not something that we're looking for. It would be hard for me to imagine a situation where that would be a good thing. But, yeah. Okay. Very interesting. What I will say is that there's an interesting sort of overlap between sports medicine, which is like a meniscus surgeon, people who deal with these younger injuries, trying to restore cartilage. And I often get, because I'm in the field of joint replacement, I get patients when they're way past the point of anything creative working. But yeah, I'd be interested. Yeah. Yeah. Definitely can be isolated, but it is far more common to have more than one joint affected. So if you had an injury that caused the arthritis in one joint, you may not be prone to getting arthritis in the other joints. But when there are genetic or body and comorbidity things, that tends to affect your whole body. Yeah. Thank you guys. Yeah. Thank you so much. I really appreciate the opportunity. Thanks so much.
All right, I just have a few concluding items that we'll leave you with. And thank you so much to Dr. Wasterlain for an awesome talk. We do want your feedback. As always, this time the survey is online for everyone. So if you visit middlesexhealth.org/Women's Fund Survey, we just ask a few questions to get your feedback about tonight and any ideas for the future. I will also ask you to save the date for our final talk of 2020. And this was scheduled probably almost a year ago, a year in advance. So this is a talk called Everything You Need to Know About Breast Cancer with Dr. Andrea Malon. She's a well-known breast surgeon in our community, and she's also the medical director of our cancer center. So that's Wednesday, October 28th. So we will share the time and the details on that as we get a little bit closer. And then finally, all of you here tonight at Parmalee Farm, many of you on Zoom are already members of the Women's Fund. You are helping to support the programs that serve women in our community. So thank you so much. If you are up for renewal on your membership, please do that. If you have a question as to when you're due, you can always ask me. And then if you're not yet a member, we invite you to join us. Sometime in the future, who knows when, we can gather together, have a meal, have a glass of wine, socialize. That's one of the benefits of this group. But for the short term, you get the benefit of giving back to women's health, to still being invited to 3 health talks a year. We were able to squeeze in 3 talks from July through October, so I'm really happy about that. And 100% of what you give goes to the project that you choose. So you can visit our website, it's there on the screen, or you can contact me directly. So thank you again, have a safe home, and thank you again for those on Zoom who joined us. So have a lovely night.